Atul Goel's video?
Yeah, this time Apita will share his talk. She's a co-worker of Dr. Goel. Yes, Apita.
Can you see?
Yes.
And you can hear?
Not yet.
My dear friends,
Yes, now we hear.
Okay.
A complete revolution in the treatment of Chiari not malformation, formation. And I'm introducing, or maybe you have already been introduced by me earlier,
Apita, we cannot hear now.
We lost the audio, yeah.
Okay, now you can.
bone anomaly in the craniovertebral
Yes.
junction. Maybe it is associated with basilar invagination. Sometimes it is associated with syringomalia and syringobulbia. Basilar invagination, syringomalia, and Chiari malformation are common clinical triads. And these kind of complex anomalies with Chiari, with syrinx are also frequent. Chiari with basilar invagination, Chiari with no bone malformation, no facetal malalignment is a more frequent understanding. And whatever slides I have shown you, if you carefully look at those slides, the posterior fossa is not tight. You see the subarachnoid spaces see the fourth ventricle. It is not a tight posterior cranial fossa. Syringomalia with manifest. You see, there is manifest atlantodental interval disturbance. This is unstable spine. We all know it. And Chiari and syrinx. So this is relatively less common. With no bone abnormality and Chiari and syrinx is a more common clinical entity. This is another case where there is no bone abnormality, no facetal malalignment. There is syringomalia and little bit of Chiari. For all these anomalies, whether it is basilar invagination associated, whether it is syringomalia associated, whether it is Klippel-Feil associated, Chiari, the important and most important issue is the whole world currently is treating these anomalies with foramen magnum decompression. Some people remove tonsils, some people open the fourth ventricle and obex and put a tube and all those kinds of. So decompression is essentially the treatment. About 15 years ago, we introduced this article that atlantoaxial instability is the nodal point of pathogenesis of Chiari malformation, and atlantoaxial fixation or stabilization is the treatment. And many of you who are in the business of Chiari have seen this article, and also you have seen the various letters to editor from a number of authors to Journal of Neurosurgery when this article was published. And these articles and discussion form an important milestone in the understanding of Chiari and in the treatment of Chiari malformation. Further, about 5 years ago, I introduced another article of mine where we discussed 388 cases of Chiari malformation or formation, where all these patients were treated by only atlantoaxial fixation. And I can tell you, my dear friends, either you read this article or you listen from me, that a magic treatment is available now for this entity. This is 5-year-old paper. Now my experience is beyond 600 cases. There is no doubt or no question in my mind. And you please don't keep any doubt in your mind that atlantoaxial stabilization is the treatment. Compression, we are all talking always about compression, and we are all doing decompression. In craniovertebral junction and in spine, my feeling is compression is always secondary to unstable spine. It is naturally protective and it is reversible after stabilization. Basilar invagination, I just want to briefly discuss the history of my understanding about this subject. In 1998, we talked about basilar invagination of two types. Type 1 when odontoid goes up, and type 2 when tonsils come down, or Chiari malformation. This only treatment for this entity was decompression in 1998. So we did transoral decompression for this and foramen magnum decompression for this. The role of stabilization was unclear. In this article, for the first time in the literature, we introduced the concept of tight posterior fossa, that there is a bony tightness in the posterior cranial fossa, and we recommended that only bone resection is good enough for the treatment. There's no need to open the dura. So I was personally doing quite a number of decompression cases. In 2004, the same entity we divided into two groups. Here we said that this is an unstable situation and this patient needs realignment and stabilization. In 2004, my concept was still that foramen magnum decompression is the treatment for group B, basilar invagination. So for group A, over the years, we have done several hundred cases where we have not done any decompression, realignment and stabilization. Realignment and stabilization is now the accepted norm throughout the world, and decompression still some people do, but decompression is not currently the accepted choice. So we have done several cases where realignment has been done. So I have no hesitation to say that we were responsible for completely demolishing transoral decompression surgery from the books of neurosurgery, and it is certainly, in my view, an historical operation. We subsequently introduced the concept of vertical facetal instability due to muscle weakness. It is more relevant to subaxial spine, for degenerative spine, for lumbar canal stenosis, for cervical spondylotic myelopathy and things like that. But it is also relevant for craniovertebral junction. In 1999, we introduced a beautiful concept where we related basilar invagination to instability, C1 over C2 listhesis, like lumbosacral listhesis. And in 1999, these images are from 1999, can you believe, 26 years ago, where this basilar invagination was related to listhesis, and realignment and stabilization was done without any kind of decompression. This is another case during the same time, Chiari, basilar invagination, C2-3 fusion. So listhesis or unstable spine is the issue, and we did stabilization. And similar other cases and several other cases where we talked about facetal listhesis as the issue. More recently, about 10 years or 15 years ago, we introduced, believe me, a complete revolution in craniovertebral junction region, where we said, and we talked about central or axial atlantoaxial instability being the cause of several so-called pathological entities like Chiari malformation, basilar invagination, and things like that. So just to briefly talk to you about what I mean by central instability, you have seen that C1 over C2 listhesis is the cause of basilar invagination, instability is the issue, and stabilization is the treatment. Now you look at this slide, type 2, the basilar invagination, there is no atlantodental interval disturbance, but you look at the facets, there is retrolisthesis. This is completely unstable and you need stabilization. So there is no atlantodental interval disturbance. Similarly, there is no atlantodental interval disturbance in this, but there is Chiari, there is syringomalia, there is assimilation of atlas and platypesia and things like that. All these things indicate unstable spine, C1, C2, stabilization is the treatment. So this is the concept. So when there is no atlantodental interval disturbance, I call it chronic instability. I call it central instability. So type 2 and type 3 are central or axial instability. So carefully look at this slide. Central or chronic instability is the cause of several. These are only very few mentioned here, but there are several more. Like Chiari malformation is due to instability. Syringomalia is due to instability. Basilar invagination is due to instability. C2-3 is a chronic, natural, protective, adaptive response to chronic instability. When Chiari is present alone, or Chiari is present with syrinx, or Chiari is present with syrinx and basilar invagination, or syringomalia is present alone, or basilar invagination is present alone, or bifid is present alone, or sodontorium, all these indicate atlantoaxial instability, and all these indicate the need for atlantoaxial stabilization. So I wish that you please read this article. If you are really interested in revolution, or if you are interested in lectures and all, then just go on listening what I'm saying. This article will give you latest information about what I talk and what I mean about central or axial atlantoaxial instability. So look at the facet. They may give some information. If the facets are normal, then also there can be atlantoaxial instability. So there is a retrolisthesis, there is Chiari malformation. Decompression is a completely negative operation in all these cases. And you do learn to do C1, C2, you create a magic with the radiology and with the patient. So there is basilar invagination. The whole world will do foramen magnum for Chiari malformation. This is a negative form of treatment in the presence of retrolisthesis, in the presence of unstable spine. You have to do fixation and you have to only see one thing, and that seeing is a magic with the patient, with the radiology. When there are complex anomalies in this with Chiari and syrinx, you have to do C1, C2 stabilization. When there is no facetal malalignment, no atlantodental interval disturbance, presence of Chiari, presence of syrinx, presence of basilar invagination are all children of one father, and that father is atlantoaxial instability. You do C1, learn to do C1, C2 fixation. Difficult. Many people question me, but how can you justify fixation in this when there is no radiological evidence? So we have started doing dynamic imaging, rotation of the head and analyzing the facets. If you carefully see that there is syringomalia, there is no Chiari, there is no facetal malalignment, but you see the facetal malalignment on head rotation. I'm not sure if you can see clearly. This is C1 facet, this is C2 facet. It is almost rubbing off the facetal articulation. Similarly, this is C1, this is C2, this is C1, this is C2. So you do rotatory imaging. So this is a new kind of thing that recently my article is published in Journal of Clinical Neuroscience. Please read it if you have time, or just listen to what I'm saying. There is Chiari and syrinx, no problem here. Rotatory, there is a dynamic rotation and unstable spine. So all these secondary issues like basilar invagination, instability is the cause. Compression and deformation is not the issue. Instability is the issue. And please have time to read this article that instability is the cause of basilar invagination and stabilization is the treatment. So for both group A and group B, there is only one treatment. Both are manifestations of chronic. Why sometimes group A, why sometimes this? You have to read these articles. And both these groups need C1, C2 fixation, basilar invagination, syringomalia, Chiari formation, assimilation of atlas are all children of atlantoaxial instability and all need one treatment, and that is atlantoaxial stabilization. So this is syringomalia, no problem here, little bit problem here. Do C1, C2, see the absolute clinical magic. Radiological magic will always be there, but more important is clinical. You want to see your patient all right. And you have to only believe me that in the evening of operation, you will find a person who's a different, you can change his name because he's a different human being. Syringomalia, Chiari, basilar invagination, no facetal malalignment, you do fixation and you see a beautiful. There is Chiari, syrinx, basilar invagination, no facetal malalignment. I am not doing any distraction. Believe me, another thing I'm saying, and be clear, I'm not doing distraction or decompression or any kind of secondary decompression or primary. Don't go under that nonsense kind of. I'm doing just unstable spine, I'm stabilizing. Syringomalia, reduced. This is another patient, and believe me, more than 600 patients. I can show slides after slides where the syrinx has reduced. No problem here, no problem here. I have done distraction here. I have described distraction here, but I don't put articular spacers now in these cases. It is not necessary. So this is another case. There is no spacer here. Difficult operation, such rostral C1, C2 for Chiari malformation, but that is the treatment. I am saying Chiari is secondary, Chiari is protective. All these things, basilar invagination is due to chronic neck pain and short neck. Torticollis is protective. Klippel file is protective. Assimilation of atlas is protective. C2-3 fusion is protective. And they are potentially or manifestly reversible. Syringomyelia is reversible in 100% of cases if you do scan after 6 months. This is in the 3rd or 4th day also it can reduce in a large number of cases. So this is syringomyelia, no problem here, little bit problem here. Do fixation and syringe reduce. Syringe reduction is not the issue. Patient improvement is, I've already told you, you will see a magic with the patient. No secondary or distraction is, no, I'm not increasing the posterior fossa volume at all. This is my concept. Posterior fossa volume reduction, that it is reduced is my concept, but I'm saying no concept. Unstable spine is the issue and stabilization, and the syringe will reduce. This is another syringe reduction, no problem here, no problem here, no problem here. See the beauty of the reduction. This is another case. This is when there is Klippel file anomaly. Now don't start decompression in Klippel file anomaly. Klippel file anomaly is one of the other children of chronic atlantoaxial instability. This is not a very remote cousin. It is a close brother of chronic atlantoaxial instability and Chiari and syringe. You do fixation, syringe will reduce. Don't bother about syringe. Patient you bother and you will see magic. So there is syringomyelia reduction, no problem here, fixation. These are not easy operations. Now people told me when I wrote this article, no, it will work only in basilar invagination, no complex Chiari, no, it will work in only this kind of situation and that. No, Chiari is second. I'm not talking of tumor and Chiari, craniostenosis and Chiari, spina bifida, I'm not talking. I'm talking of even when there is no bone abnormality. So there is no bone abnormality, syringe and Chiari. So what you will do here? So there is no bone abnormality, little bit facetal anomaly on lateral profile imaging. There is syringomyelia, you do fixation. There is no bone abnormality, little bit problem here on lateral profile imaging. Now, of course, you do dynamic rotation and see the magic. And possibly, if you have time to really read this article, please read it. So there is syringomyelia reduction. I'm not doing any distraction of facet. I'm not doing any kind of secondary decompression. I am doing just stabilization. Instability is the issue and stabilization is the treatment, and a beauty is the clinical outcome. So you see this syringe, no problem here, no problem here. The syringe reduces, and that is the issue. Syringomyelia reduction, no problem here, no. And if somebody argues, no, I don't know, this patient did not improve, that patient did not improve. If you don't know how to do C1, C2, only God can help you. This is a concept. I'm not trying to be too aggressive. I'm not trying to be too possessive, but this is the revolution and this is the future. When I'm saying I'm talking of 600 patients, you say, I don't believe. If you're not believing, come and spend some time with me. And if you don't want to spend time, then don't talk or read the article. Syringomyelia, Chiari malformation, syringomyelia, no problem here, little bit problem here. Do fixation and see the magic. There is syringomyelia, no problem, reduction, C1, C2 fixation. So as I mentioned to you, there are several hundred patients lined up with me where all this syringomyelia reduction, and one patient is lying with me in the ward today. He said, Doctor, I love you. Yesterday I operated and today morning, Doctor, I love you. That is the satisfaction, that is the gratification you can get. Syringe reduction. This is another 1 year after surgery, syringe finish. It will never finish actually. There is some kind of syringe and there is syringomyelia. When there is failure, as I mentioned, I introduced the concept of tight posterior fossa. Many of my own patients have continued to have problems. What you do with, now my most common operation which I am doing nowadays is the failed, people have done foramen magnum and they are coming from all over the world. And This patient failed, somebody has done foramen magnum decompression, see the syringomalia. See, I'm showing you Syrinx cases more because it is more, visually seen. If I say there was no Syrinx and I did for Chiari, it is not so much visually seen unless you see the patient and give me about 5 to 6 hours of presentation. In 10 minutes, I have to show you the world of Chiari in a different perspective. So there is Syrinx, there is Chiari, there is foramen magnum. This patient underwent 13 operations. And a very high profile person, completely demolished by this concept of decompression, which I introduced in 1998. Understand, you see this rise to this catheter. This is immediately after third or fourth day, he's having straight neck, not so miserable, rise tube gone, speech comes back. There is Syrinx, no problem here. No, somebody has done foramen magnum decompression. He lost his voice. He got CSF leakage. Multiple operation, several days of ICU, and then this is a new life. When I wrote this article, someone, no, it will not work in pediatric age, it works in only adults. Completely not correct. Chiari in any case is relatively less common in children. These patients will have more sleep apneas. So there is Chiari and Syrinx, no problem here, no problem here. We do fixation, the Syrinx will reduce. As I mentioned, the Syrinx will reduce 100% of patients. Clipper file abnormality, see the Syrinx, see the bad kind of issue, and see the postoperative situation. So these are secondary. All these children are secondary to unstable atlantoaxial joint. Syringomalia is secondary. It is naturally protected. It can present, this one child can present alone without Chiari. Chiari can present alone without his sister syringomalia or without basilar invagination. But if whichever child is there, the problem is father. To treat the father Syrinx, nobody knows how to treat idiopathic Syrinx. Here is the answer for you. And here is the article for you to read. We have introduced a new concept of external syringomalia, another kind of a revolution in the field. You have to read this. There is Syrinx inside the cord, Syrinx outside the cord. This outside is external syringomalia. This has same implication as internal Syrinx, and it has got huge implications in understanding spine surgery. Kyphoscoliosis is another child which is a little bit remote cousin living in another town. Kyphoscoliosis may be secondary to central instability. It may be associated with his brothers like Chiari and Syrinx, or may be associated without Chiari and Syrinx. And when there is Chiari and Syrinx, so the whole family is here, the father, treat the father, and the scoliosis will be treated. Don't start putting rods after rods, and this result will be in the immediate post of this after 3 weeks of operation. See, the spine has become straight. You would have introduced several screws and several rods and demolish the person. Scoliosis and syringomalia is a subject. Rotatory dislocation can be a cause of kyphoscoliosis. It can be idiopathic dorsoscoliosis. Nobody knows what is the treatment. Eye movement disturbance can be present due to Chiari malformation. There is no problem here. Don't start decompressing. This needs stabilization. This kind of eye movements disturbance is quite a frequent issue in Chiari. The voice quality affection, sleep apnea. Sorry for this. And the other thing, beautiful thing I'm saying, you do fixation on the table, you can get 40 or 50% recovery in motor evoked potential. You cannot undermine these kind of observations. Either you don't, want to listen to this, or you don't want to just open your mind. This is Chiari and Syrinx. During operation, you see this motor evoked potential more than 40%. So you can create heroes, you can create smiles, you can create laughters, and you can be proud. And you can be and you can also get some beautiful kisses from all over the place. This is a revolution. Believe me, don't try to argue too much. Spend some time instead of argument on the papers, and you will find some beautiful answers. Foramen magnum decompression is historical. C1, C2 fixation will emerge as a more powerful tool in the treatment of various anomalies of the craniovertebral junction. Thank you very much.
Thank you, Abida, for sharing that. Unfortunately, as always, Atul has run out of time about by 15 minutes, but that's okay. We know him, so we'd spare him for that. Let's start discussion. So I'd start with requesting Mehmet to say a few words, and then we move on to our panel, all the panelists.
Yeah. It seems that it is still a challenging disease, very unique portion of the human anatomy, and it is not just covering the brainstem and spinal cord, but also having big rotational movements, and